Welcome to QI Connect, our first session of 2021. And can you believe it? This is the 64th session since we began. I'm Ruth Glassborough, Director of Improvement at Healthcare Improvement Scotland, and I'm your QI Connect Chair. QI Connect provides an opportunity for colleagues across health and social care to learn from international leaders in the fields of improvement, innovation and integration. So welcome to QI Connect. I'm now going to pass you over to Jess, who's going to tell you how it works and how to use the Q&A function to submit your questions for our speakers today, Drs Trzeciak and Anthony Mazzarelli. Jess.
Thank you, Ruth. So I'm just going to take you through some housekeeping notes for MS Teams Live. So you will not be able to use your mic or camera in a live event, but you will still be able to hear and see the presenters. At present, it's not possible to interact with other attendees via chat, but you can upvote any questions you see in the Q&A by liking any submitted questions that you particularly like to see put to the speaker. Please use the Q&A function to submit your questions for the speaker. These will need to be moderated, so it may take a minute or two for your question to show up in the live chat. This session will be recorded, and by taking part you consent to this, and a recording of the session and resources covered will be made available along with the slides following the session date. Okay, so to use the Q&A function, if you look at the top right hand of your screen, you'll see the speech bubble logo, and when you click on that, the Q&A panel will show up. And you can use that to submit your questions using the text box shown. And when your questions will show up in the My Questions tab, and then once they're approved, they will show up in the featured panel. And as I said, you can like any questions that you would particularly like to see put to the speaker, and that will give them priority in the Q&A box. And a summary of resources covered will be made available along with the recording after the session.
Thank you, Jess. So, as well as staff across health and social care services in Scotland, we now have over 1,300 organisations linking in, including 89 universities and colleges. Next slide, please. So some of these organisations are based in other countries, and we now have 65 countries represented in our QI Connect community. Due to time differences, many of them will be watching this via the recording, but for those of you who are joining in person, please do feel free to flag when asking a question where you're joining us from. Next slide, please. So delivering QI Connect is very much a team effort, and what an amazing team it is. And thanks, in addition to the team, to the NHS Scotland National Video Conferencing Service, who continue to provide us with excellent support for MS Teams live events. Next slide, please. So please do remember to tweet as you learn and use the QI Connect hashtag, tag in at Connect QI and give us a follow. So I am delighted today to introduce our guest speakers, Drs Trzeciak and Anthony Mazzarelli. Due to their local guidelines, they are going to be joining us today with face masks, a sight I'm sure we're all too familiar with. Having read their book over the festive holidays, I know we are in for a real treat today. The evidence that they have collated about the impact of compassion on healthcare is mind-blowing and highly relevant to the challenges our health and care systems are facing globally at the moment. So Dr. Drs Trzeciak is a Professor of Medicine and Chair of the Department of Medicine at Cooper Medical School of Rowan University. And he's also the Chief of Medicine at Cooper University Healthcare. He is both a practicing intensivist and a clinical researcher with over 100 research publications in the scientific literature. Dr. Anthony Mazzarelli is co-president and CEO of Cooper University Healthcare, and he's also the Dean of Clinical Affairs at Cooper Medical School. So in addition, he continues to practice emergency medicine at Cooper, and somehow they also managed to find the time to write Compassionomics, an amazing book that should be a must read for everyone in healthcare. So it's my pleasure now to hand over to them to talk us through some of their key findings. Stephen and Anthony.
Hello, everyone. I'm Anthony Mazzarelli. I'm the co-CEO here at Cooper University Healthcare and a practicing emergency medicine physician.
And my name's Drs Trzeciak. I'm a professor and the chair of the Department of Medicine here at Cooper in Camden, New Jersey.
So we are delighted to be here. It's really an honor. And we do these talks all the time. Typically, we do them alone. We don't really get the opportunity to do them together. So we're delighted to have the chance to do that. And we're going to try to do it back and forth a bit, a little bit conversational. And we really want to highlight certain elements that we think are the most important. And realistically, we could talk about this we can talk about compassion for hours, and in fact, we have. And then when you add in the fact that we're talking to each other, we could probably do it for days. But we're not going to, and we're going to limit our comments to 30 minutes. And but when either of us start talking about compassion, we typically always start the same way, which is we start with a story. So Dr. Trzeciak, Steve, please start.
Thank you. So on February 27th, 2007, on a snowy stretch of highway outside of Uppsala, Sweden, two buses collided head-on. This slide shows you what was left of one of the buses. It was such a complicated extrication of the victims at the scene that it literally made its way into the annals of a disaster medicine textbook. Tragically, 6 people died, but miraculously, 56 people were saved. Now, 5 years later, researchers asked a question. The question was this: what do survivors remember? They used a rigorous qualitative research methodology and interviewed every survivor. And what they found was 2 common themes in the data. The first was expected. It was the physical pain that they felt at the moment of impact. But the other theme, a lack of compassion from the caregivers at the hospital. And what's even more striking is when you read the methodology of this paper and you realize that the victims were taken to multiple different trauma centers, but they had the same experience. These data began to open our eyes to a stark reality. In healthcare, we're in the midst of a compassion crisis. Now, you may say perhaps we have a compassion crisis in society in general, and there are data for that. So, for example, a meta-analysis from the University of Michigan has found that empathy among college-age students has been declining over time over the past 2 decades, and the rate of that decline is actually accelerating. A Harvard study of 10,000 middle school and high school age students found that the students acknowledged that they believe their parents value their achievements and their accolades more than their kindness for others. And in a striking Pew Research study in the US in 2016, almost 1/3 of Americans endorse that they don't believe compassion is part of their core values. But what about healthcare? Healthcare is supposed to be different. And in a US study that was published in Health Affairs, 46% of Americans said that not only do they believe that our healthcare system is not compassionate, but they also believe that our healthcare providers are not compassionate. Numerous research studies have found that physicians specifically miss 60 to 90% of opportunities to respond to patients with compassion. Our colleagues from the Mayo Clinic have found that the median time to first interruption of a patient when they come to a clinic visit is just 12 seconds. And other research has shown that physician statements to patients in the context of an office visit, compassion only comprises 1% of physicians' communications with patients. Now, in my domain, critical care, I'm an intensive care specialist. research from Johns Hopkins has shown that 74% of interactions between ICU staff and patients and families in the ICU have no expressions of compassion. And even at the end of life, a University of Washington study funded by the National Institutes of Health in the US found that 33% of end-of-life conversations in the ICU had zero communications of compassion between the ICU team and the patients and families. And if there was ever a time when somebody needed compassion, it would be at the end of life. There are also some new emerging data that show that in the present state, in the era of electronic health records, clinicians spend more time looking into their computer screens than looking their patients in the eyes. This slide that you see is a famous painting by Luke Fields. It's called The Doctor. This is actually a painting that I have hanging on my wall in my office at Cooper. The reason why I have it hanging on my wall in my office is because it's a constant reminder to me about what taking care of patients is supposed to be all about. If you notice, this physician, this doctor, is totally locked in to his patient. He's totally in the zone, so to speak. There's nothing you could do to distract this physician from the patient, this young girl who is gravely ill, who is under his care. I'm going to contrast that with another work of art, this one more recent, this one from 2012, and it was published in JAMA. And it was submitted by a pediatrician, and one of his patients, a 7-year-old girl, drew this piece of art for him. And it depicts a scene in the physician's office. You'll note that there's the mother, the patient, and the patient's sister on the right side of the screen. On the far left side of the screen is a physician. What's the physician doing? Looking into a computer screen. And where are they facing? Completely the opposite direction. The physician, the pediatrician, was actually mortified that this was how his young patient actually viewed him. So based on all of these data and many more, we conclude that we are in the midst of a compassion crisis indeed. But that begs the question, does compassion really matter?
So we think most people will say, of course it matters, but really, does it matter in meaningful and measurable ways? That's really the question. So the first step, and even before we talk about anything, we want to put something out there. So we don't have any magical thinking, right? So we want to give this caveat. Nothing is more important than clinical excellence. So no amount of compassion can make up for the slip of a surgeon's knife or if someone's given the wrong medication, but it certainly can do a lot. And we're going to talk about the impact of compassion as we go through this, or at least a small part of the impact of compassion today in the time that we have. So we want to back up to tell you the methodology that we use to see how much science there is in what traditionally is considered the art of medicine. So this is the part that's great for me because I usually get to talk about Steve and he's not here when I get to do it. So I get to make fun of him a bit. This all goes back, at least my part of the journey from my point of view, was when in 2000 and late 2013, early 14, in late 13, I was named the chief medical officer of our health system. And the first thing our CEO did is she challenged me to increase our patient satisfaction scores and our physician engagement scores. And she said, don't worry, I'm giving you this fancy consultant that we hired that will help you do it. So I met with the consultant, and the consultant gave me this list of things to do with patients that in order to increase the amount of compassionate care we give. And I have to tell you that the list seemed kind of mushy to me. It seemed like soft things to do. And it seemed to me it was going to be very hard to get this, at the time, about 500 faculty to do it. Now we're about 750 employed faculty for a brand new medical school. It just seemed like it was going to be hard to get the group to do it. A group to practice evidence-based care, to give them these sort of mushy things to do. So my thought was to turn to our #1 NIH researcher, the person who everyone knew was the epitome of science at Cooper, who had the most publications, the most grants, the person who, in reality, and he's going to be embarrassed I show you this, had the reputation, had published in all the biggest journals, who, this, by the way, is a picture. You can't see Steve's expressions because he has a mask on. This is him being about as expressive as he gets in this picture. This is, and he's famous for saying things like, without data, you're just another person with an opinion, or in God we trust, but everyone else needs data. This is what he was known at our institution for, and was really, his focus was on resuscitation research and sepsis. In his free time, he would write editorials in the New England Journal. And I went to him and I said, I want you, Steve, to be our champion in patient satisfaction, physician engagement on these list of items to increase compassion. And he said, that's not really my thing, right? I'm the resuscitation guy. And I said, look, I need you to science this up. Is there data behind what we're doing? And he was going through a bit of a, I think, well, what would you call it that you were going through at the time?
An existential crisis.
About the research you were doing. Right?
Exactly. The purpose. The purpose.
And so he went and started to look at this data, and we were amazed at what we found. And the methodology that was used at the end was, we ended up looking through 1,000 abstracts, over 280 research manuscripts, and ultimately what we found, it wasn't what we presented in Compassionomics, what we're talking to today. It's not what we think or what we believe. It's really what we found. And we reviewed essentially every single article in the biomedical literature that had to do with compassion, with empathy, with increasing that relationship between those that provide care and those that receive it. And that's ultimately what we want to talk about today. And we call that branch of knowledge of scientific study of the effects of compassionate care on health care, so the delivery of care, and on healthcare providers, those that deliver it, Compassionomics. So if the study of the economy is economics, or the study of genes is genomics, that's where we came to the idea of calling it Compassionomics.
Essentially, we're looking at something familiar in an unfamiliar way. So compassion is familiar in a moral or ethical sense, or a sentimental, emotional sense, but we wanted to look at it through the lens of science, and that's what we did with our methodology.
But what are some of how does it change outcomes? The first piece of that.
Well, first, let's talk about definitions.
That's right, Steph. You have to define, what are we even talking about with compassion?
Sure, just to make sure that we're all on the same page. In any scientific pursuit, the first step is to make sure that you have a common nomenclature. And most scientists define compassion this way. Compassion is the emotional response to another's pain or suffering involving an authentic desire to help. So it's slightly different from a closely related but distinct word, empathy. So empathy is the detecting, sensing, feeling, and understanding another's pain and suffering, but compassion goes beyond detecting, feeling, sensing, and understanding. It goes beyond empathy to take action, to help in some way, to help alleviate someone's pain or suffering in whatever way is possible. And there are neuroscience data to support this distinction in terms. So neuroscientists, using a modality called functional MRI, so brain scans that can tell you what areas of the brain are being activated at any point in time. When you bear witness to suffering and you have empathy, it actually activates the pain center of your brain. So the statement, I feel your pain, there's neuroscience behind that. But when you take action to alleviate someone's pain, that actually activates a completely distinct set of neural structures, different brain areas, actually the reward areas of the brain that are associated with positive emotion, positive affect, affiliation. It's the feel-good reward center of the brain. And that's why we believe that the neuroscience points to the following, that empathy hurts, but compassion heals. So now that we've talked about what the terms are, let's talk about outcomes for a second. So of the 280 original science research papers that are cited in Compassionomics, more than 100 have to do with outcomes for patients. Of course, we don't have time in the short period today to talk about 100 different research studies, but I can summarize them for you in that they really fit into 4 different categories. So let's start with the practical. For example, quality of care. So research shows that if you care deeply about patients, you're more likely to be meticulous about the care that you provide and have lower likelihood of a major medical error. So another practical area is self-care. If you care deeply about patients, they're more likely to follow your instructions and they're more likely to take their medicine. So for example, a Johns Hopkins study of 1,700 patients with HIV asked these patients one question: does your HIV provider know you as a person? Know you as a person. After adjusting the analysis for every factor that they could measure that they knew that was associated with adherence to antiretroviral therapy, what they found is that knowing the patient as a person was associated with a 33% higher adherence to antiretroviral therapy, as well as a 20% higher odds of having no detectable virus in the blood. The next category is physiologic. So there are physiological effects. For example, compassion can modulate stress-mediated disease. It can modulate a patient's perception of pain. I don't want to minimize pain. It is one of the most complex areas in all of medicine, as illustrated by the fact that there are actually specialties just in pain management. But compassion from a trusted other can modulate a patient's experience of pain. This has been shown in experimental science studies in a laboratory with experimentally induced pain. It's also been shown in patients with postoperative pain, been shown in patients with low back pain, pain due to migraine headaches, and abdominal pain related to irritable bowel syndrome. There's also evidence in diabetes, for example, that maximal compassion from the patient's perspective is associated with a higher odds, actually an 80% higher odds of having optimal blood glucose control and 41% lower odds of having acute diabetic complications requiring admission to the hospital. And even in patients with a common cold, maximal compassion from the patient's perspective has been associated with a 15% lower severity of symptoms for patients with the common cold and 15% lower duration of symptoms as well. And lastly, psychological effects. It may be intuitive that compassion can attenuate symptoms of depression. We perhaps know that from all of our very close personal relationships, but it's also shown to be true in the clinical context, that compassion from the part of a therapist or a psychiatrist, a psychologist, compassion is associated with lower depressive symptoms in patients who are suffering from depression, lower anxiety symptoms in patients that suffer from anxiety, lower psychological distress in patients who suffer from serious somatic illness like cancer. And in research from our group here at Cooper, we've even shown that compassion from caregivers in the throes of a life-threatening medical emergency is associated with a lower risk of subsequent development of PTSD, post-traumatic stress disorder, from the ordeal itself. And so for all of these reasons, these four categories, quality of care, patient self-care, physiological effects, psychological effects, the preponderance of evidence suggests quite clearly that compassion matters for patients, not just in, as Maz said, meaningful ways, but also in measurable ways.
So we talked about there's the idea of health, the healthcare system, and those providing care, the three different branches we say comprise Compassionomics. So outcomes are the actual health of patients, but what about the delivery of care? So we often think about it in costs. It's something we really focus on in the US, so maybe you wouldn't think we would with how things balloon out of control with costs, but we think about what about the delivery system? So to focus on just a few aspects of that. So one of them is, Steve already talked about, is adherence to medication. So to think about the delivery of care in that aspect, I mean, in the US, it's estimated that there's could be as much as $289 billion a year. That's cost of medication non-adherence in the US healthcare system. So that's extra care that we're providing because people don't adhere to their medication. And you can chip away at that if people are more adherent, and they will be if there's more compassion in the interaction they have with those that provide them care. And another aspect of the healthcare system in the US that you can think about is compassionate care reduces the amount of tests that we do. So when you provide patient-centered care, you have people who order less tests. It reduces the specialist referrals. You lower hospital admissions. You decrease overall charges. So, and then the failure to provide that patient-centered care has been shown to have 11% higher spending on diagnostic tests, 3.5% higher total healthcare spending, And so in one study, the median charges overall were 51% lower with patient-centered care. So the delivery system itself is changed with respect to having more compassionate care. And so can the environment that you work in. So compassionate workplaces benefit not only the patients, but also the people that provide care. So if you have a strong culture of compassion, in one study, which was a long-term living type facility, that not only did the people they called it a culture of companionate love. And so when they moved to that kind of culture in that facility, they noticed that those that provided care had a better experience themselves. Teamwork went up, absenteeism went down, emotional exhaustion went down. They had a better experience working in that environment. And of course, that led over to the patients. They had less visits where they were sent to the emergency department. Their quality of life went up. So the delivery system itself benefits from having an environment in which there's more compassion, not even just to the patients, and also in the way that they treat each other. And when you think about this, I'm sure the first thought is, yeah, but how much extra time does it take to do all of this? And so now we need to address that.
And that's where a striking number comes from the research that we did for Compassionomics. And the number is this, 56. In a Journal of General Internal Medicine study from several years back, 56% of physicians said that they don't have time for compassion. But it begs the question, how much time does it actually take? Researchers from Johns Hopkins University wanted to know the answer to that question. And so they studied it in a randomized controlled trial in cancer survivors. The primary outcome measure for this study was patient anxiety. Now, if you've ever been touched by cancer, whether you yourself or perhaps someone that's close to you, you know that anxiety is a pretty important outcome measure. So in this randomized control trial, which by the way used a well-validated scale of patient anxiety to measure the outcomes, they randomized cancer survivors to one of two arms. The first was a consultation with an oncologist that was information only. The other group was an enhanced compassion arm where they got the exact same consultation from the oncologist with just information, but then a little bit more. And I could describe it for you, but instead, I think I'm just going to read it to you. So from the oncologist at the beginning of the consultation, I know this is a tough experience to go through, and I want you to know that I'm here with you. Some of the things that I say to you today may be difficult to understand, so I want you to feel comfortable in stopping me if something I say is confusing or doesn't make sense. We're here together, and we'll go through this together. And then at the end of the consultation, again, from the oncologist, I know this is a tough time for you, and I want to emphasize again that we're in this together. I'll be with you each step along the way. So how long did that take? Well, the researchers measured it. It was 40 seconds. And the study subjects, the cancer survivors randomized to the enhanced compassion had statistically significant lower anxiety scores after being treated with just 40 seconds of compassion. So the evidence suggests, and we found actually 5 other studies that we summarize in one of the chapters of Compassionomics, that shows that on average, compassion takes actually less than a minute for a meaningful communication of compassion to patients. But then why is it that our healthcare providers think that it takes so long to treat people with compassion? And it's a question of mindset, really. So for example, a study from the University of Pennsylvania studied something called time affluency. Time affluency. That's the feeling that you have plenty of time, that you're not in a rush at all. And they randomized subjects in their study to 4 different uses of time. One was spending time on yourself. The second was wasting time. The third was getting an unexpected windfall of free time. And the fourth was spending time on other people. So there was only one of those 4 uses of time that was associated with an increase in time affluency, meaning the feeling that you have plenty of time. It was spending time on other people. So if we're going to be evidence-based about it, the evidence points to the fact that spending time on other people actually gives you time. So giving time gives you time. It's a question of mindset. And actually, some of our colleagues, as Maz knows, they bristle at this suggestion that it takes any time at all, that there should be no time dimension, because they tell me you can go through your day with brusque efficiency, letting people know exactly how busy you are or how busy you think you are. But the truth is, if you went through your day treating everybody with compassion, if someone were to hold a stopwatch to you, it actually wouldn't take any more time at all. The last thing I think we should talk about in the few minutes that we have remaining is burnout.
Which is particularly important when you think about what's happening globally with the pandemic.
Yeah, the data in the U.S. and in the U.K. and across Europe as well points to the fact that we have a burnout crisis in healthcare, and that was before coronavirus, right? So I want to talk about burnout because I think it's important, and really for me, this is where the science meets the personal. So I'm an intensivist, and working in the ICU, one of the ways to describe what we do is that we meet people and their families on the worst day of their life. And so after 20 years of working in the ICU and meeting people on the worst day of their life, I came to the stark realization that I had every symptom of burnout myself. So what was I supposed to do? And so I looked in the medical literature because I'm a research nerd, to be honest, and that's my go-to. So I went to the literature and I looked, and what I found was that the recommended treatments for burnout were things that I considered to be, quite frankly, escapism. Go on more vacation, take more nature hikes, go do more yoga, or put on your headphones and do your meditation app and just escape. As if the cure or the antidote for burnout was just to get away from my patients as much as possible. And to be honest, I just wasn't buying it. It just intuitively, it didn't compute. I believe that something fundamental had to change at the point of care. And that's right when we were working on Compassionomics. And I remember being taught, and I know Maz remembers this as well, when we were in medical school decades ago, I remember being taught as part of the hidden curriculum, so to speak, don't get too close to patients, don't care too much, because too much compassion, too much caring just burns you out. The problem is when you look in the medical literature, when you look in the evidence, you actually can't find strong evidence to support that. In fact, there is an association between compassion and burnout, but when you look at the evidence, the association is inverse. So it's not high compassion, high burnout, low compassion, low burnout. It's high compassion, low burnout, low compassion, high burnout. And what could possibly explain that? What could explain it is that if you don't connect with patients, if you don't have those compassionate connections with patients, then you don't get the fulfilling part of what it means to take care of patients. You don't get the good part of it. So then all you're left with is a really stressful job. And so after going through all the evidence and being aware that compassion, that there's data, there's abundant data that compassion can be a powerful therapy for the giver too, I decided to do an experiment on myself. I call it my N of 1 experiment. One, because there was N of 1 just because there was only one study subject in the experiment, and that was me. And so I decided, and by the way, you have to be very intentional about this, very intentional. I decided I was going to care more, not less. Lean in rather than pulling back and detaching. Sit down and spend more time with patients and with families rather than less. And that was when the fog of burnout began to lift for me. It changed everything. And I want to be really clear about this next point. You don't have to be an ICU doctor. You don't have to be a physician. You don't have to be a nurse to feel burned out, especially where we are right now. And so for all those people out there in your viewers today, that are feeling that way, I suggest that you test the compassion hypothesis for yourself and see how it transforms your experience.
So in sort of summing up what we talked about, there's really only 4 reasons that we may not treat patients with compassion, to really lean in the way that we're talking about. The first would be you don't think it really matters, but I think we've talked about some of the data today and why it does. You think you don't have time, but we talked about how you really do have time, right? 40 seconds, less than a minute when you put 5 different studies together. You don't care, but that's the burnout that you can solve by doing this. The last would be you don't know how, but we didn't talk about it today, but there's lots of data that you can train. It's not just that you're either inherently someone who's compassionate or not. And so in the end, compassion really does matter. Compassionate care is evidence-based medicine, that there is science in the art of medicine, at least in part of the art of medicine, and that science is strong. So we're really happy and very honored to have been here today. We want to thank everybody, Ruth, David, Jessica, Michael, thank you everyone who we interacted with in preparing to be here today. And now we want to take the opportunity to answer questions.
Great, thank you so much, Anthony and Stephen. And the chat, the question and answer box has been absolutely alive. There are so many questions coming in. There's no way we're going to have time today to answer all of them. But we are going to start, first of all, with our guest questioner, Anne McLinton, who's the Programme Manager for Person-Centred Health and Care at NHS Greater Glasgow and Clyde. Anne, over to you.
Thank you, Ruth, and thank you to Stephen and Anthony for that really insightful presentation. I feel really compelled now to read your book tonight. So my question, I think in part you've already answered, but I'd like to ask, how can we define the key dimensions of compassionate care, measure these and support healthcare staff to develop the skills, attitudes and behaviours reliably to convey compassion in our care and conversation with patients and relatives?
Anne, thank you so much for that question. We love the question. Essentially, while we talked about the definitions of compassion and the distinction versus empathy, I think you're talking about defining it in the clinical context. And how is it that you measure compassion? Well, we had that question as well. We had it because on clinical grounds, because we care very much as physician leaders in our organization what our patients think of the way that we take care of them. So for a clinical quality standpoint, we wanted to be able to measure compassion from the patient perspective. But we're also researchers. And if you can't measure compassion, it's very hard to test hypotheses about it. So we developed a 5-item compassion measure. And we published this last year, or actually in 2019, in the journal called JAMA Network Open. So it's the open access journal for JAMA. And what we did is we developed a measure from the patient perspective of compassionate care. Our methodology was that we started with a systematic review of all the measures that have been published before in the literature. We then tested that in 3,000 patients. We then found that the most parsimonious and from a psychometric testing perspective, the best questions were a 5-item compassion measure. And then we validated that in another 3,000 patients. These were all in the outpatient realm. We subsequently also validated it in an emergency department population. We just finished validating it again in an inpatient hospitalized patient population across 96 hospitals in the United States. The 5 questions for the 5-item compassion measure, and they work always, usually, sometimes never. How often do your healthcare providers consider your emotional and psychological well-being? Are attentive to your personal needs? Know you as a person? How are they able to gain your trust? And lastly, show you care and compassion. Those are our 5 questions, and the psychometric testing around those questions are as rigorous as any other scale of patient experience that we measure here in the US. And so that's our instrument. And so we're measuring that now at Cooper clinically because, again, we care about what our patients think about how we show them compassion, but we're also using this in multiple research studies. The second part of your question is how do we support healthcare staff to develop these skills, attitudes, and behaviors that convey compassion? And that gets to a point that Maz was saying right at the end of his remarks, and it's all about training. And so I used to believe that you were either wired for compassion or you're not. It's something in the fabric of who you are. It's in your DNA. And either you're a compassionate person or you're not. When you look at the available evidence in the scientific literature, and that's what we did, and we actually have a whole chapter devoted to this in Compassionomics, the available evidence shows that you can, in fact, learn compassionate behaviors. And the operative word is behavior, because patients don't know what you're thinking or feeling in your heart or your mind, but they do know how you behave towards them. And we can, the preponderance of evidence shows that we all can, in fact, get better at compassionate behaviors. We may start at different levels based on a variety of factors, but the data shows quite clearly we can all, in fact, get better. In fact, we were collaborators and co-authors on a systematic review that was published in 2019 in PLOS ONE, the journal PLOS ONE, that was a systematic review specifically for physicians analyzing all the training programs for empathy or compassion that have ever been tested in the biomedical literature. What we found is that there are actually 54 studies, and 75% of those studies moved the needle on compassion in some measurable way, and usually from the patient perspective. So one last part about training that I'll mention is that a growth mindset is essential. So some of you may be familiar with the book Mindset by Dr. Carol Dweck from Stanford University from years back. It definitely has permeated our educational system in the United States. The gist of the book is that if you have a fixed mindset, meaning you believe that what you're being measured on are traits rather than skills, something inherent to you rather than something you can learn, you're less likely to work at it and get better. But if you have a growth mindset, meaning that you believe things like compassion and empathy are skills, not traits, you're more likely to persevere through perceived failure. You're more likely to work at it. You're more likely to work hard at it, and you're more likely to get better. So Dr. Dweck and colleagues also have done a study on empathy and compassion. And what they found is that those people who believe that compassion is a skill rather than a trait, those are the people that actually will work hard at it and will get better over time. So having a growth mindset and realizing that you can, in fact, get better is essential for a more compassionate culture in our healthcare organizations and, quite frankly, for a more compassionate society.
And there's something else you can do too. Part of your question was, how do you support staff in doing this? Which is, you try to remove all the roadblocks you can to allow staff to interact with patients. So it's trying to make sure everyone's working top of license. It's trying to make sure that you do everything you can to allow people to have that interaction. So to have that in the back of your mind, that those feel like process things, those feel like administrative things. They don't feel like they're in the realm of Compassionomics, but they really are. When you think about what are the things you're doing to allow people to interact with patients, those are things that are in this realm too, and that will help those compassionate interactions happen.
Great, thank you so much. And as I say, the Q&A box has been just full. We've got, I think, 36 published questions, so I will just pick a couple out. Some of them you've actually already answered through the course of your presentation. But one that's been voted for a lot is one that you've partly touched on around this relationship between burnout and compassion, and you helpfully covered that. What the question asks, though, is in the context of the COVID pandemic, where we know that individual clinicians are sometimes having less opportunities to demonstrate compassionate behaviours because of some of the restrictions that are there. Do you have any thoughts on that, on how is that going to result in an increase in burnout? Are there other things we could be doing around showing compassion within these very difficult circumstances?
Thank you for the question. Without a doubt, we are higher risk for burnout than ever before because of the demands placed upon us and the barriers to connecting with people, at least in the physical sense. And one of the things that we found through all of our research, and I'm going to go right into your question in just a minute, but I want to say this loud and clear, is that the preponderance of scientific evidence shows quite clearly that the key to resilience is relationships. So the key to resilience is relationships. It's relationships with your patients, it's relationships with your colleagues, it's relationships with your friends and family. Relationships are where we're going to feel emotional uplift, and the evidence is quite clear on that. So leaning into our relationships all across the board are one of the best ways to protect yourself against burnout. Without question, we are in a high risk time for burnout. And what I have witnessed in my ICU here at Cooper and throughout our health system is something that psychologists call elevation. So elevation refers to a state of emotional uplift that you feel when you bear witness to another's moral excellence or heroism, or for that matter, more compassion in a time of crisis. One thing that I have felt throughout this entire pandemic, ever since it started, I have felt quite consistently elevation from the heroism of my colleagues at Cooper. And it really starts with the nurses. Dr. Maz and I like to say that we learned how to be doctors. We learned how to take care of patients from journal articles and from textbooks and from mentors. But that's how we learned how to treat patients, but we learned how to take care of patients from the nurses. And we actually dedicate Compassionomics. We dedicated the book to all the nurses because they're the ones who really taught us how to take care of patients and how to connect with compassion. But our nurses have given us such elevation because we're witnessing heroism and more compassion like we've never before. It's just different. And what I mean by that is that patients can't have loved ones by their side in the hospital anymore while we're under restrictions. Imagine being in an ICU bed and you can't have your loved one at the bedside, or imagine being that loved one and you can't be at the bedside of your spouse or your friend or your family member, and how difficult that must be. So we've had to look for other ways to connect. And one of those ways is through FaceTime. And we've had just remarkable stories of how we've had to leverage different modalities for human connection in order to provide the compassion that we're used to. I believe our colleagues have gone above and beyond, and that's what's really buoyed up my spirits and given me elevation during this really difficult time.
Yeah, I mean, the way I think about it is, that inability to connection, like Steve's saying, is everything. So that inability to connect means that there's, and also for the patients unable to be with their loved ones because of the visitor restrictions, is there all of our staff not only working the long hours, is they're getting the empathy portion where it lights up the negative parts, the negative emotions of their brain, and they're not able to fire off the positive portions, which is to act on it with the compassion, through the connection and the compassion. That imbalance is ripe for the disaster, right? Because that's going to cause more burnout. And so that's where you have to find ways to make up for it. And whether there's the elevation of seeing all these moral acts, creative ways of doing things for patients. And I'll give you some concrete examples, that we knowing that we need to find ways to light up those positive emotions in the brain, the reward centers in the brain. It's celebrating the wins. It's holding the birthday party for the ICU patient that isn't even awake and recording it and playing it for his or her family. It's making those connections you can. It's celebrating every time you get someone who is intubated off the respirator as a unit. It's keeping track of those numbers of positive wins and celebrating through the institution. If you can do those things, you can start to light up those positive parts of the brain to counteract all the empathy where you can't connect and get the compassion. So it's using the science to sort of guide being able to counterbalance things during a time where it's a lot harder to do when you normally could, which is just lean in a little bit more like in Steve's N of 1.
And I'd like to share just one more thought as it relates to the COVID pandemic that we're facing right now. And that is something that we don't talk about too often in medicine, but perhaps we should talk about it more. And that is hope. Hope. So I've heard it defined. In fact, Senator Booker, who wrote the foreword to our book, defines it this way. Hope is the conviction that despair will never have the last word. Hope is the conviction that despair will never have the last word. And the reason why I raise this for everyone's consideration today is that hope is sometimes dismissed. It's dismissed as this sort of Pollyanna-ish notion that good outcomes will occur when there's no reasonable evidence to support that it will. We don't buy into that. We actually think that hope is essential, and hope is especially essential in the era of the COVID pandemic. And so the data support that compassion for others is a powerful restorer of hope. And so some people, like in business, for example, sometimes they'll say, well, hope is not a strategy, but we believe that hope is necessary for every strategy, including our strategy for getting through this pandemic. And if you want to buoy somebody up and restore their hope, one way is to connect with them in compassion.
Such a powerful answer. Thank you both. So Anne, who's a physiotherapist in Scotland, is asking whether or not there's any variation in compassion across different countries, or whether or not you've noticed any variation across different types of healthcare providers, i.e. acute, community, primary care. Are there any differences that stand out from the research?
Well, one thing that we found in our research is that compassion is valued essentially as a universal. So almost every culture, every religion, every country in which we know it's been studied by anthropologists, that compassion for others is considered a core value. Perhaps historically there have been some outliers with that. I'm not an expert in that, but in general, compassion is considered a core value by almost as a universal or across many different cultures. And we believe that the evidence for that is very strong. As it relates to different healthcare providers, I would just go back to our comments just a little bit ago about nurses. We consider them to be the experts in compassion. In fact, we went through 280 original science research papers and that we included them all and cited them all in Compassionomics. And the nurses that have helped to shape the kind of doctors that we are today have actually said, well, it's intuitive. You didn't even need to go through all that data. Why did you even do it? Because we've known this in the domain of nursing. We've known this all the way back to the origins of nursing. This has been something that we knew we didn't need 280 original science research papers. But for those of you who did, it's right there for you.
And there is data that physicians are not so great at telling about how compassionate they are, but nurses are good at telling whether those physicians are compassionate when you look at the patients actually judging it. So, which is probably not a surprise when you hear me say that.
And to your point, Maz, what we would call it is a blind spot. There are a number of published papers that show that physicians specifically, and no offense to physicians out there, Maz and I are both, we're in the club too. Physicians often have a blind spot as it relates to their own compassion, where they think their connections with patients are better than when you actually ask the patients. And so that's why training is important, and having a growth mindset and believing you can always get better. Physicians always try to get better at the scientific, technical part of their craft. Why not also take the approach that we need to get better at the human connection part of our craft as well, and continuously over time, as a continuous learner, get better at human connection and connecting with patients. And that just brings me to one last point, is that we want to be clear about one thing. Maz and I, we are works in progress. You might think that because we wrote a book about compassion science, because we've been invited to this forum to talk about compassion to all of your viewers, that we must be the most compassionate doctors. But the truth is that we're just works in progress. Very much so, both of us. The difference is now that we see it. And so we're working hard to get better at compassion every day. And thankfully, science shows that we can.
Fantastic, thank you. And you have just put a massive smile on the face of every nurse on this call today. Thank you. I'm going to squeeze in one final question. So Julie is highlighting that we have lots of bundles that exist for various treatments and procedures. What do you think about the use of a compassionate care bundle to reinforce the need to be compassionate? Could this help improve patient outcomes?
Well, what we did in the paper that's published in PLOS ONE, it's Dr. Patel and coworkers, which includes Dr. Maz and I, is that we found that compassion training works. Compassion training works, and 75% of the studies showed that they move the needle on compassion in some measurable way, often from the patient perspective. So that's good news. That being said, we acknowledge that of those 54 studies that have been tested in the biomedical literature, they were very heterogeneous about what it was in their curriculum and the behaviors that they taught. So we believe that, we acknowledge, first of all, that from a quality of care standpoint, bundles make things better. We know that. That's settled science. We don't need to debate that, because that's settled science. What should be in a bundle for compassionate care? There could still be, at the present time, some debate about that, because I think we're just at the start of finding out the evidence base for what specific behaviors are the best at communicating compassion, communicating caring. So I think there's still some work to be done on that, but that's precisely why we published our paper in JAMA Network Open last year, to measure it from the patient perspective, because that will allow us to help detect which behaviors are the most meaningful from the perspective of our patients.
But the lack of saying, here are the exact 5 or 10 things to do, doesn't mean you don't start trying to do something. Because, like we said, you know, Dr. Patel's study shows that 75% of it's going to make a meaningful difference and move the needle. So the idea is the intentionality to make a difference is, you can look at that study, pick some of these different behaviors. The intentionality, the desire to do it, and the growth mindset means that if you pick some of these things and consistently do it, it's leaning in and doing it is where you're going to make a difference, and you're going to find that difference pretty quickly.
And so in Compassionomics, we test the hypothesis that compassion matters for patients, for patient care, and for those who care for patients. And so that meaning our healthcare providers. So if you just have a growth mindset and try small steps, what you're going to find is not only does it make your care better, but you're actually going to feel better too. And that's not the why, right? We connect with patients with compassion because we have, it's a cornerstone of the art of medicine. We have a moral and ethical obligation. But once you realize that there's science behind it, then you're in the mindset that compassion matters. And as you do those behaviors, you'll actually start to feel better yourself. That's not the why for doing it. You're doing it because of your duty to your patient. The byproduct you will experience is that you'll feel better yourself. And that's, again, to Maz's point, it's not our opinion. It's not what we think. It's not what we believe. It's what we found on a 2-year journey through the scientific evidence, 1,000 scientific abstracts, 280 original research studies, that compassion matters not just in meaningful ways, but also in measurable ways.
And what a perfect note to end on. Thank you so much. You have inspired us. You have challenged us. I'm certainly going away challenged and inspired to act. Thank you on behalf of everybody on this call today. And if you don't yet have the book, I can personally highly recommend it, Compassionomics. So just to remind everyone on the call, we will be convening again in March with Professor Jason Leach, who is, I know, very well known to many of us on this call, and it promises to be another insightful and thought-provoking session. And of course, the rest of our back catalogue is available for you to watch and enjoy on our website, or you can visit us on the QI Connect YouTube channel. So it just remains for me to say thank you to everyone for joining us, and hopefully we will see you all again next time. Thank you.